re-invite Dr. Amit Pandey. He's going to summarize some of the major evidence that we have with regards to tubes. Amit.
Thank you again, ma'am. So I'll be talking about these four landmark studies: the tube versus trab, the primary tube versus trab, Ahmed versus Balwilt, and Ahmed-Balwilt comparison. These studies have sort of shaped our understanding and management of glaucoma surgery, and I'll be reviewing their aims, methods, results, conclusions, and limitations. Also, we'll have a discussion on the clinical implications in our practice. This is stopped. Okay. So the first one is the tube versus trab. The aim was to see the safety and efficacy of tubes versus trabeculectomy with mitomycin in patients who had previous ocular surgery. Previous ocular surgery being either cataract surgery or a filtration surgery, but patients who had extensive scarring of the conjunctiva were excluded. All these studies are multicentric randomized controlled trials. They had 212 patients randomized into either Balwilt, which 350 mm square, or a trab 0.4 mg per ml for 2 minutes, and they saw the IOP and safety. At 5 years, trab had better IOP control, but not clinically significant. What do you call it? It was statistically not significant, yeah. And failure rates was also a little higher with trab group. The change of visual field damage progressing was slower with trab group, but again not statistically significant. They identified diabetes, high IOP, and more severe visual field loss at baseline were the risk factors for progression. Complication rates were also mentioned to be higher with the trab group. So the key findings was that I'm not going to go too much into statistics and numbers, just going to highlight the key findings. Success rates, they told that the tube had higher cumulative success rates at 3 years and 5 years, and IOP reduction was also similar in both the groups. In the early postoperative phase, the trab, that is the first year, trab group had better IOP control than the tube group. Complications were more with trabs, but late and serious complications were similar in both the groups. Wound leaks were more frequent with trabs, and diplopia and of course motility disturbances would be higher with the tube group. Vision loss, no significant difference at 3 years and 5 years, and medication use, trab had lesser medication use in the first year, but again with time it became similar to the tube group. They concluded that tubes may be a little more effective in maintaining IOP control with fewer complications, and but they did not conclude that one procedure would be universally superior. Instead, it provided a comparative insight for us surgeons to make individualized decisions. The limitations of the study were that one thing is that this was partially standardized surgical techniques. Some major part of the surgeries were not standardized across all the centers. Coming on to the second one is the primary tube versus trab. Like I told, the first study had a previous surgery. This was without any previous surgeries. They randomized into Balwilt versus trab and had similar IOP at 3 years. Failure rates was also comparable. More complications with trab. So they concluded that the primary tube surgery may be a viable alternative to trab because of lesser complications. But again, limitation was that this was only Balwilt, so it might not apply to the other implants. This was one more publication out of this study about reoperation. This was interesting. Reoperations of glaucoma in these two groups. Tube had much higher reoperation rate than trabs at 3 years, and those patients who underwent a reoperation, in them IOP control was at the end of the study was similar, but the number of medications in the trab group was lesser, again not statistically significant, and the probability of failure was also significantly lesser in the trab group, but they could not reach significance statistically. Coming on to the third one, it's the Ahmed versus Balwilt. They compared the Ahmed with the Balwilt. in refractory glaucomas. 238 patients randomized to either Ahmed FP7 or Barwell 350. At 5 years, Ahmed had the Barwell had the lesser mean IOP. Failure rates were higher with Ahmed, and complications, hypotony related complications were more with Barwell. Barwell provided a better long-term IOP control but higher initial risk of hypotony, and Ahmed had fewer complications early on but was less effective in the long term. A similar study, the Ahmed-Barwell comparison, also compared these two devices and had similar results, with Barwell getting better IOP control, lesser medication burden, and Ahmed getting higher failure rates. Okay, so what do we imply from what implications do we derive from these studies, especially for our practice in India, is that we get a lot of late presentations. So these surgeries are very significant for us, and TRAB, I would say that TRAB still remains the first line surgical option in these late presenters or advanced cases because of the cost effectiveness also. Tube implants should be considered for higher risk cases, including failed TRABs and secondary glaucomas. Affordability and accessibility is something that we need to understand. So the conclusion is that the value of these landmark studies does not come from showing superiority of one operation over the other, but rather in providing comparative data on the outcomes of both surgical procedures that help the surgeons in selecting the most appropriate glaucoma operation for their individual patients. Thank you so much.